get going. So I bet you all are Zoom professionals at this point in the pandemic. I think if I had told people 3 years ago that virtual meetings would be the way of the future, then I'm not sure everybody would have agreed with me. But here we are. So hopefully you know how to use this system. I see people are already using the chat, which is great. You can mute and unmute yourself. I do want to welcome any kind of comments, questions, concerns, needs that you all have. Please feel free to be vocal. If you can't get a word in edgewise, because I tend to talk a lot, feel free to use the hand raise feature, which is part of the reactions emoji, probably at the bottom of your screen. We are going to record today's meeting. So if you're uncomfortable with that, feel free to turn off your camera, feel free to log off right now, feel free to hold back if you are not comfortable being represented on that video, but it is for people who aren't able to attend today's session, or in case you want to reflect back on the content that's presented today. And if you need any technical assistance, Emily Trey is in the background and she can definitely help you. So her email address is here on the screen. She can also be reached in the chat box. You can send a direct chat to her, or you can send it to everyone, and we'll make sure that we support you. We want to make sure that you have the most engaging experience possible in today's webinar. So great. And so that you have some context about where we are, this is part of a 12-part training series by the Injury Prevention and Control Program here at the Massachusetts Department of Public Health. Today is focused on infant safe sleep, but we've got a load of really great trainings coming up that you all can engage in as well, from abusive head trauma and paid family medical leave next month, to QPR, which is a suicide prevention training, self-care, secondary trauma and grief in December, transportation safety in January, concussion, bike and ped safety in February, falls prevention in March, and then positive and adverse childhood experiences in April. Since you found your way here, I'm betting you know how to register for these sessions, but the link is on the slide in case you want to follow up and register for any of those other sessions. I really hope that we do see you in some of those other sessions. And here we go. We're in the infant safe sleep training for family support service providers. Our learning objectives for today's session are for you to be able to support clients in practicing safe sleep and reducing harm in the infant sleep environment. Oh, Alexandria, we have a question in the chat. Could you, oh, thank you, Emily. Really appreciate it. So great to have, I always say teamwork makes the dream work, and it really does. The second learning objective is to have some tools and strategies for approaching safe sleep conversations, especially during phone or video visits, when you're not necessarily in place, might not be able to see the infant sleep environment. And this is really where I want to tap all of your expertise and experience as well, because I'm not on the front lines. I can tell you about the policies and the data and some of the programs that we have going on, but you all are the experts in supporting families and having these hard conversations with family members. So I want to make sure that you teach and learn from one another. And then we're also going to talk about accessing grief services in the wake of an infant or child death, since unfortunately these deaths do occur, and I imagine that a lot of you have experience with needing to support a family or caregiver network that has experienced a loss. So I want to make sure that you're aware of the resources and services available here in Massachusetts. So here's our agenda. This is how we're going to accomplish those learning objectives today. We're going to talk a little bit about the definitions of sudden unexpected infant death. We're going to talk about SUID prevention through a framework of risk and protective factors. We're going to dive deeply into room sharing versus bed sharing. We're also going to talk about strategies for caregivers and have lots of discussions for you to share with one another on what works, or what your experience is, or what your challenges are. And then we're also going to talk about promoting safe sleep in your work, and then get into the accessing grief services. So there's just a couple slides towards the end. I'm going to try to pepper in some movement breaks and some time for you all to sit back and relax and listen. So we'll try to do a mix up. If at any point you need to stretch your legs, feel free to do so. You know, I learned recently that a lot of times when we go to didactic trainings, we're engaged in and invigorated at the time, but we don't necessarily carry those lessons forward into our work because it doesn't really get into our body. So if you're a tactile learner, feel free to do that fidget. If you need to talk, you chime right in and talk, whatever it is that helps you internalize this information and move it into the future. And then I also want to just reflect on your experiences with SUID and SIDS. I have a friend who did have an infant who died from SIDS, and I'm betting that a lot of you also have experience in this space, whether personally or through your network. And I just want to acknowledge that the loss of a child can be a difficult conversation. This is a hard conversation when we talk about infant death. So we completely understand if you're having some big emotions or deep emotions related to this topic, if you need to take a step back and take care of yourself, that is your priority, is taking care of yourself. You cannot take care of other people if you're not first taking care of yourself. So please take a deep breath, take a step back, come back when you're ready, or if you're not ready and you want to watch the recording some other time, all of that is completely acceptable. And also just wanted to let you all know about 988 in case you haven't heard about 988. This is a new 3-digit number for getting mental health crisis support. So it's kind of a spinoff on the suicide prevention lifeline, but this is for all people in any kind of mental health crisis. So if you want someone to talk to about your experiences, please feel free to call, text, or chat the 988 lifeline. Any questions or concerns before we dive in? Languages that 988 supports. I'm not sure. I will get in touch with 988, with our suicide prevention director. Actually, yep, she's on vacation right now, but I will find out that information and get it out to you as soon as I can. All right. Alexandria or Emily, would it be possible to share the slides with the registrants so that they can follow along on their own? We'll see how that goes. But I'm going to keep going in this space. Thank you, Emily. I'm going to keep going in this space. I hope my attempt at a social worker pause was satisfactory to all of you. It's hard to take that silence for a moment. Thank you, Emily. All right, so what is sudden unexpected infant death? SUID, sudden unexpected infant death, is the death of a child under the age of 1 where a cause is not immediately known before an investigation. This is the leading cause of death among 0 to 12-month-olds nationally and in Massachusetts as well. SUID is essentially broken into 3 different categories or subcategories between SUID. One is what is commonly referred to as SIDS. This is a much more popular and known acronym than SUID is, but this is actually a subset of SUID deaths. So sudden infant death syndrome, or SIDS, is when no apparent cause can be found for the infant death. It means they simply don't know the cause for SIDS. And then accidental suffocation and strangulation in bed, ASSB, is a SUID when there was a risk factor in the sleep environment that may have caused the suffocation or strangulation. And it's this is done in the investigation phase. So this is things like soft items or blankets in the bed, window cords that might wrap around a baby's neck, etc. So this is when their breathing is blocked or stopped by something in the sleep environment. And the third one is undetermined cause. An undetermined cause, this means after a thorough investigation, it's still not clear what the cause of death was. They haven't been able to rule everything out, so they can't call it a SIDS death. They don't know if it was caused by strangulation or suffocation in bed. It might have been a respiratory issue where they had a cold or some kind of infection, but they haven't been able to rule that in as the cause of death. So when it's not clear, when it's not a clear-cut SIDS death or not a clear-cut ASSB death, it gets classified as undetermined cause. And in terms of what we're seeing in data, this is national data from 1990 to 2020 about SUID deaths. We can see that the overall rate, the combined SUID rate here, has really seen some nice reductions, but it has flatlined in the past few years. We've really leveled out in terms of the progress we've made in preventing overall SUID deaths. And when we break that into those three categories that we had talked about on the previous slide, we see that sudden infant death syndrome really models that nicely. It's the SIDS portion of it, that part where they have absolutely no reference point for what actually caused the death, that has decreased substantially as well. And this unknown cause has crept up a little bit, and so has the accidental strangulation and suffocation in bed. Part of this is because we're learning more. We know more. Prior, a lot of these cases were considered SIDS without the nuance of a sudden unexpected infant death, that undetermined cause, or the strangulation and suffocation. But overall, when you really combine these, you see that it has evened out, or flatlined over the past few years. So we're trying to push the word out and help support family support service providers in understanding some of the risk and protective factors that we do know about in an effort to prevent both SIDS and accidental strangulation and suffocation in bed. Now, we're lucky in Massachusetts. Massachusetts actually has one of the lowest rates of sudden unexpected infant death in the United States. We have made really great progress. Part of this is because our systems and institutions are just so strong. We have such great access to healthcare and other social determinants of health, which I'll get into in a minute. But any death of this kind is a tragedy, especially for the families who are walking through it. So even though we have a really low rate, we still want to make sure that we can get that rate even lower. And you can see, so I'll go to the next slide. So in an average year, there's about 30 infant deaths from SUID in Massachusetts. That's about almost 2 classrooms worth of kindergartners who are not attending their first day of school because they died of sudden unexpected infant death. And while this number is very low compared to other states, we see a lot of inequities in the data. So we see that the lowest rate of SUID is among the Asian Pacific Islander non-Hispanic group, and the highest is among Black non-Hispanic infants. There's a lot of reasons for these inequities. We see these inequities perpetuated in a lot of other causes and manners of death as well. So there's something in the groundwater, something that is affecting our people of color in Massachusetts and causing premature death more so than other age groups. And just to note that the American Indian Alaskan Native population, the counts were too low to be able to produce a stable rate, but it does also appear that they are overrepresented in the SUID data as well. So when you're thinking about the populations that you serve, it's important to keep that in mind to help improve equity. Before I move on from the data slide, does anybody have any question about the data or the definitions that I've provided so far? Okay, I counted to 14 in my head. It's never too late to ask a question. So as long as if you're still in this meeting and something came up about that data that didn't make sense, or you want a little bit more nuance, feel free to pop that in the chat, raise your hand, and I'll circle back to these data slides. So let's talk a little bit about prevention, because that's ultimately what we're all here for, right? We want to make sure that the families, the people in Massachusetts live to their full potential throughout their life course. So best way to do that for an infant is to prevent SUID. I want to note here that all of our health outcomes are affected by social determinants of health. So these are the things that the conditions in which we live, work, and play that can really put us at risk or prevent a lot of health outcomes, or negative health outcomes, or positive health outcomes. This is Kira, this is the part where I get into some of the theories about the racial discrepancies with SUID. So I'm going to try to answer your question in just a moment. So a lot of these social determinants of health in the national and international literature are based on economic stability, neighborhood and physical environment, education, food, community safety and social context, and the healthcare system. So when all of these social determinants are working well and applied equitably and everyone can access the same way, we expect that we wouldn't see as many inequities in our death data or our negative health outcome data. Unfortunately, because of institutional and historic racism, not everyone has access to these social determinants of health, or they have inequitable access to these social determinants of health. And all of these we know actually impact rates of SUID. So for example, in the healthcare system, adequate prenatal care has a major influence on gestational outcomes for both the parent and the infant. So things like being able to get adequate prenatal care can improve birth outcomes like the gestational weight of the baby and the experience of the pregnant person. Similarly, access to food has implications for the quality of nutrients that the fetus is getting, as well as the pregnant person. And economic stability certainly reduces stress, allows for access to a lot of these other social determinants, etc. So you can start to see where when we are built on a system that has marginalized certain groups or certain people and prevented access to these social determinants of health, it affects all aspects of life and produces inequities that are not genetic in nature. They're not because of the innate experience or the biology of a person. It's really because of the conditions in which they live, work, and play. And our goal here at the Department of Public Health is to make sure that everyone has equitable access to these social determinants of health. Kira, did I start to answer your question? It's a big one to unpack. And if you didn't see, Kira put into the chat if she has a question about if there are any theories as to why there are racial discrepancies in SUID. And our SUID outcomes look a lot like our maternal mortality outcomes, where Black non-Hispanic women are dying at higher rates from pregnancy complications than white women who are of the same age or the same socioeconomic status. So it does come back to these social determinants of health and how people are accessing programs, services, and getting the resources and support that they need. We also use a framework in thinking about this on protective factors and risk factors. So protective factors are things that exist that can protect or prevent the negative outcome from happening. And the risk factors are things that exist that can increase the risk or the likelihood of something happening. Now, a caveat for today's presentation that I just want to point out, we're going to talk about a lot of individual behavior today. So things that the caregiver does, things that the infant has experienced. We have seen from that flat line in the data where we're really starting to balance out that the individual activities alone are not sufficient to prevent SUID. We really need to think systemically as a society about social determinants of health and how to make sure that every pregnant person has adequate access to prenatal care in a non-judgmental, easy to access way. Everyone has economic stability, housing stability. The stress that comes from not being able to fulfill your social determinants of health is very detrimental to both the pregnant person and the fetus. So while we're going to talk today about individual level behaviors, because that's what you and I can impact on a day-to-day basis, that alone is not sufficient to prevent especially SIDS moving forward. So that's one piece that I want you to bring back to your organization as well, is thinking about these social determinants and looking at your data, stratifying by race and ethnicity, by socioeconomic status, by all of these other social determinants to figure out what might be the root cause and help your agency and organization push the envelope forward so that we can really address the social determinants of health as well as the individual level behavior. I don't want anybody to think that that by taking this training, it is an automatic fix for SIDS. There's a lot that we can do here to prevent SUID, the accidental strangulation and suffocation in bed in particular, but a lot of the SIDS pieces, they're really from that groundwater that's infected through historical and social race and historical and systemic racism. And I I bring that out too because we hear a lot of times from family members who have had an infant who died from SIDS about their experience and the stigma that they've experienced and the self-doubt that they have about what could I have done differently to prevent my baby from dying. And a lot of times these are folks who put their baby in a crib, put their baby on their back, didn't smoke, did all of the right things, and their baby still experienced SIDS, and now they don't have their infant. So you as frontline caregivers and providers, I want to make sure that you hold that in your head and make sure that the people who are walking through this experience, that you can reassure them that they're good parents, they've done what they did. It's not the time when someone experiences a loss, it's not the time to do any kind of blaming or introduce any additional doubt into this system. So there's a lot we can do to support people and build those communities so that they can practice safe sleep, but that's not a guarantee that an infant won't die from SIDS. They just want to, it's like holding on to two different things at the same time, both really hard things, but they're both equally valid. All right, question for you all, pop quiz. Which of the following is not a risk factor for sudden unexpected infant death? The possible, and we'll do, oh, Stephanie's already chiming in. Exposure to tobacco smoke, placing blankets and pillows inside the crib, baby sleeping alone, or overheating. All right. Nobody's going to try a different answer from C? Did Stephanie just give a total spoiler? Good thing Stephanie gave you all the right answer. Oh, we've got an A and a D. All right, so we've got a couple other ones. The correct answer is baby sleeping alone. So this is not a risk factor for SUID, with a couple of caveats in there too, where it is really helpful to have room sharing. And we'll get into the difference between room sharing and bed sharing in just a moment. But exposure to tobacco smoke is absolutely a risk factor for SIDS. We've seen a lot of evidence about brain development and respiratory development and how tobacco, nicotine, and even potentially marijuana smoke can impact brain development in an infant and a fetus. Placing blankets and pillows inside the crib, it's an absolute suffocation hazard. It's really dangerous for an infant. They cannot rescue themselves from a blanket that gets in the way of their breathing. And overheating is another one that is a bit of a risk factor for SUID, although the American Academy of Pediatrics has recently kind of stepped back a little bit on this. But overheating can really cause, babies are at high risk for overheating. They can overheat very easily. So it's important when we're talking about the sleep environment that they're comfortable and cozy, but not too hot, because that can really affect their systems, their biological systems. All right, some other risk factors for these little babies, which one of my favorite parts about providing these trainings is being able to look at all the cute sleeping babies. They are so sweet when they're asleep. So age less than 4 months. The peak of when we see SUID is between the 1 and 4 month mark. That's not to say that it doesn't exist beyond that. Typically, we see a drastic reduction in SUIDs after the 12-month mark. So that whole under 12 months is really, we consider that a risk period for experiencing SUID. But that less than 4 month part, that 1 to 4 months, that's really where it's a critical time. Genetics and family history. So if a sibling has died from SUID, the new infant or a next infant has a higher risk for also dying from SUID, which is just really tragic to think about. But there's also some other genetic and family history characteristics like seizure disorders and other things that epilepsy, for example, that can put an infant at higher risk. So it is important to have that understanding of the experience of other family members and really wrapping heads around what kind of level of intervention, what level of risk might this infant be at. And then low birth weight. So this is especially true. We talked earlier about women of color and the poor gestational outcomes that many experience. The low birth weight is definitely on that category. And this puts infants at a higher risk for experiencing SUID. And so that's a low birth weight of 5.8 ounces or preterm birth. And you can have a heavier infant that's born preterm, and the risk is still there regardless of the birth weight. So we try to list those out as two separate risk factors. And then one thing that we've seen in the data as we've been unpacking and looking at each of these SIDS cases is respiratory infections, colds, and congestion. So this would probably put them in the undetermined category for under SUID, but it's important to think of that in terms of bed sharing and co-sleeping as well. So that's a particularly high risk time for an infant. And it's also a time when caregivers really want to keep the baby close, cuddle them, comfort them. So it's just important to keep that in mind about the need to comfort the infant, but still provide an extra safe sleep environment for them. And then we also covered prenatal or postnatal smoke exposure. And in Massachusetts, because we do have adult use marijuana, we want to make it really clear that this is smoke of any kind. And that includes vaping as well. So those were some of the biological risk factors for the infant. Here's some risk factors that can exist in the environment. So these are all things that in our individual behaviors and actions can be addressed. So the sleeping position of an infant, back to sleep, back is best, back for every sleep is the best. And we'll get into why in just a moment. And the type of bed, so water beds and soft surfaces, futons, couches, chairs, car seats, those are all very risky sleep environments for an infant. Things in or around the bed, blankets, stuffed animals, pillows, strings, cords, or ropes, wedges or positioning devices, which a lot of doctors still recommend, even though they put the baby at risk for rolling down and getting entrapped in their own crib. Those all pose risks for infants and should be avoided in the sleep environment. Other people or pets, so this includes siblings, this includes caregivers, parents, and it includes the cat, the dog, the iguana, whatever you have in your home. Those can all pose substantial risks for an infant in terms of rollovers and entrapment in the bed. Room temperature and sleep attire. The hotter it is, the worse it is for the infant. It's really nice to keep a cool sleep environment, and we'll get into that a little bit. And we talked about smoke of any kind. And this is the best way to remember this, in my opinion. The ABCs of safe sleep. Give me a little hand if you've seen this messaging before. Has anybody seen the ABCs of ABCs of safe sleep before? Jessica, you have? Great. Right, we got a little thumbs up. Great. A few other people coming in and saying they have. And Kira did ask, are pets only a risk if they're in the infant's sleep environment? That's a great question. I've never seen it as a risk beyond the sleep environment. It really is about the pet potentially blocking the airway of the infant. But I suppose if the infant has asthma or some kind of allergy, there might be another risk, but it's not, in that case, it's not considered a SUID. That would be if an infant died of an allergic reaction or something from the pet, it would be classified as a different kind of death. All right, so lots of you have seen the ABCs. So I don't have to go over it, but it is a really helpful acronym when you're working with parents and caregivers. Alone, back, crib. And you'll probably see that more than once today too. So let's talk about why back sleeping is so important. This is probably the piece that that comes up the most with caregivers, with parents, is that the thought that sleeping on their back might put them.
You're welcome.
Jen, I think you're unmuted if you want to mute yourself. Okay, great. So it's important. So oftentimes caregivers will think that back to sleep will put baby at risk for spitting up and then choking on their spit up. And I can understand where that comes from. We certainly talk about that with adults, where if an adult has drank too much alcohol, I know I received training when I was a teenager, put them on their side, don't let them lay on their back. If they throw up, they can breathe it back in. But this simply isn't the case for infants. Adults have a lot more voluminous spit up and throw up than infants do. And also the way that our esophagus and our trachea are built, the amount of spit up that comes up can actually, if the infant is on their back, slide straight back down their trachea. So what you see is that the trachea or the breathing tube is on top and the esophagus or swallowing tube is on the bottom. So you can see here, when a baby spits up, it might go up and then come straight down the esophagus and head into the stomach. Whereas if the infant is on their stomach, the spit up will come up the esophagus and go down the trachea, which means it will go into their lungs and cause choking. Shelly, I think I saw your hand come up for a moment. Happy to take a pause and take your question if you have it. Oh, I see it in the chat. Does DPH have literature or info for moms and dads in other languages? Any posters that we can post in the shelter? When data is collected for SUID, is the immigrant population included? Haitian Creole, etc. In short, we do have a safe sleep conversation guide that I'll get to later on in this presentation that is available in Spanish and English. We don't have any posters available because we wanted to do justice to the topic in terms of focus testing the translated materials, and we didn't have resources to conduct those focus groups and focus tests. So we didn't want to put something out that wouldn't land with the population in mind. So we don't have posters in other languages, but there are a lot of national resources that are available in other languages, and we can walk through those as well. And yes, if an infant dies in Massachusetts, they are collected in our data. Haitian Creole will be in the Black non-Hispanic category. So that's where that's represented. We haven't broken them out in terms of immigration status or first versus second generation, but we do know from the national literature that the risk increases with the amount of time in the United States. So much like many of the other negative outcomes like obesity, etc., the SUID rates are lower in many other countries. And Michelle asked, do you run any parent workshops or virtual information that we can resource parents? Do we have lots of videos and information that you can use with your parents? We'll get into those today. But we focus on you all at the Department of Public Health because you all reach more people than we could ever reach on our own. So we're leveraging you as a network to get the information out to parents and caregivers. And we'll get into those resources later on in that presentation. Okay, so back to the trachea versus esophagus. So I hope that makes sense. There's a little animation here just to show. So again, when baby's on their back and they spit up, it goes up the esophagus and then right back down. If they're on their stomach, it goes up the esophagus and then down their trachea. This is not good news for an infant who has very sensitive systems. And then safe sleep surfaces. So these are all wonderful CPSC, which is the Consumer Product Safety Commission, safety approved cribs and bassinets. So you can see a regular crib, you can see a pack and play, a bassinet, and you can learn more about safety approved surfaces by visiting the Consumer Product Safety Commission, and they have some more information about it. Some of the things to look for in these, if you're working with a family and you're not sure whether or not it's a safety approved crib or bassinet, one thing is no more drop sides. If the crib has a drop side, it is a risk factor. We had a lot, not necessarily for SUID, but we had a lot of infants losing their fingers and toes due to drop sides. So drop sides, even if it's locked up, not a good idea. Good idea to help them find a new sleep surface. If it's got any bumpers on it, bumpers are not a good idea either. They're a suffocation hazard, and a lot of states have actually banned the sale of bumper pads. We saw bumper pads were kind of necessary with the drop sides because of those finger and toe losses, but that's not a thing anymore. And also, if you can fit a soda can between the slats of the bed, the slats are too far apart and it's a risk for the baby's head to get stuck between the slats. So we don't need bumpers anymore because the slats should be nice and close together so that baby's not getting entrapped. And one thing I do hear from a lot of people is like, what if my baby's arm gets stuck or their leg gets stuck in the slats? We're not worried about that. You know, we'd rather see an infant who's uncomfortable and wakes up and cries because their leg is sticking out the side of the crib than an infant that's at risk for suffocation because of a bumper. So it's, you know, it's just helping families think through the risks in these sleep environments are really important. Some unsafe sleep surfaces. These are all not safe sleep surfaces. If baby falls asleep or if caregiver and baby fall asleep in these, they should move as soon as they are able to rouse themselves and wake up and move. One of the negative outcomes that we saw in the recent past, when the American Academy of Pediatrics first came out with their infant safe sleep policy, where it was said that co-sleeping or co-bedding with an infant is not allowable, we saw a lot of women trying to breastfeed, trying to stay awake in the middle of the night and moving onto these couches and chairs. And we saw infants falling and we saw brain injuries increasing. We saw entrapment in these really soft, cushy, comfy cushions on the couches and chairs that also led to suffocation. So it's important to remind people that these are not, you cannot fall asleep, baby can't sleep on these, they're very dangerous. Same thing with car seats. And there are still a lot of pediatricians who will recommend sleeping in a car seat. Those are special circumstances where perhaps the baby has some kind of GERD or acid reflux that requires them to be propped up a little bit, but they still need a lot of supervision when they fall asleep in car seats, especially if their chin is falling down and getting tucked while they're in the car seat. That can cause them to not be able to breathe. So you want to make sure that the car seat at least is set up in a way where the infant's head is back so that they can keep their airways open. All right. And then nothing inside the crib. And this includes that cute teddy bear. It includes the quilt that was made by a favorite aunt. It includes a lot of culturally sensitive things for a lot of families, like the amber beads, etc. Those all pose choking or suffocation hazards, even if they're laid over the edge of the crib and not directly in the crib. Want to make sure that the whole sleep environment is free of any of those pillows, cushions, blankets, etc. Wedging devices, ropes, you name it, it needs to be out and away from the baby's crib. Otherwise, it can put the baby at risk. Until what age should there be nothing inside the crib? I recommend until at least age 1. We don't have a lot of good evidence or recommendations from our national partners or in the literature about the age that it should stop. But since we do see such a drastic reduction in SUID counts and rates past the age of 12 months, it's generally okay to, to start using a pillow at age 1. But, you know, try to also put some logic around it too. Baby doesn't need a full-size comforter when they're 1 year old. A baby pillow is better than a full-size adult pillow. Multiple pillows in the crib are probably not a good idea. Things like that. Just so it doesn't need by age 12 months. It doesn't need to be a completely bare crib, but it also shouldn't be overly stuffed. Okay. All right, room temperature. So we talked about this a little bit. We're going to dive back in. So keeping the room between 68 and 72 degrees is ideal, although it's a very limited temperature range, and especially when we're talking about social determinants of health and economic stability, etc. This might not be achievable and attainable for all people. I personally don't have an air conditioner in the summertime. There's no way that I can keep the room at this temperature. In the winter, similarly, it's pretty hard to keep my house stable in temperature. So what's important here is making sure that They know the approximate temperature range that's great for an infant while they're sleeping. And then they think very strategically about how baby will be dressed when they're sleeping. Because we already said no blankets. And so if we're saying it has to be 68 degrees, which is not attainable for everybody in Massachusetts, and they can't use a blanket, one of the strategies here is to put multiple layers of pajamas on. So rather than trying to put in a blanket or a swaddle, etc., is just making sure that baby is bundled with extra layers of clothes. And in the summertime when it's hot, just a diaper or whatever works for the family. But just making sure that they're not over bundled. If at any point baby is red or sweaty, that is not a good sign for the baby. I know there's a lot of Massachusetts moms who get really worried about baby being warm enough in the winter and tend to put lots of blankets and extra clothes, etc. on top of it. Babies are really sensitive to overheating. So it's important if babies shouldn't be sweating or red. That's not a good sign for baby's health. So making sure it's not over bundled. And Trisha, I see your question in the chat here. And Jessica, what are our thoughts on earrings? A lot of parents pierce ears at a young age and they can't take those earrings out. And Trisha similarly said, we're seeing infants with jewelry, pacifiers as well. That's a sensitive topic that you're going to have to work through and really leverage your motivational interviewing skills. I haven't heard of any cases where earrings were causing a problem. They tend to be really tricky to take out for an infant. They don't have that mobility. So I don't necessarily think that one's a risk, but the amber beads, wooden bracelets, etc., we've seen splinters, we've seen choking. Generally speaking, we don't advise use of those objects. And there's other culturally specific jewelry and attire. So there might be things like, while baby is sleeping, put it on a window or somewhere nearby so that it still has that protective effect for the infant according to their culture, but isn't on the infant, causing a risk during sleep time. And pacifiers are actually, I can't remember if I included that slide in here. Pacifiers are a wonderful protective factor for infants. And even the AAP expanded their recommendations recently that even newborn infants can use a pacifier even before breastfeeding is well established. Pacifiers help infants clear their airways, and it helps them keep themselves slightly roused as they're sleeping. So one of the big factors that we see is like that very, very deep sleep where babies can't rouse themselves. That's actually not a good thing. So having a pacifier lets them stay a certain level of arousal, which will help them wake up in the long run. Oh, and pacifiers will be coming up in a couple slides. So we'll get back into that in just a moment, but I hope that answers some of the jewelry questions. Another question that we get is around swaddling, which is the practice of wrapping an infant tightly in a blanket to prevent free movement. Swaddling is great as a comforting mechanism for a fussy infant or a crying infant. It's an incredibly important tool for caregivers and parents who are trying to get any kind of calm, peace, or rest that they can possibly get. But what we've also seen is that when infants' movement is restricted that much, they have even less of an ability to help themselves if something goes wrong. So we recommend that if a parent or caregiver is swaddling the infant, they remove the swaddle before placing the infant in the crib for sleep. This helps the infant keep their arms out and allows for a little bit more free movement for them to rescue themselves in the case that something goes wrong. Swaddling is not an evidence-based practice for preventing SUID. It is an evidence-based practice for calming a fussy infant. I hope that distinction makes sense. And this is slightly different from what some of the advice that people may have been given in the past. All right, smoke exposure. We've talked about this one a few times, but I wanted to give you some resources. The Massachusetts Tobacco Cessation and Control Program, which is in the same bureau that I work in, has some wonderful resources to support, especially pregnant people in quitting smoking. So I want to highlight this Quit Now line. Make sure that if you come across a caregiver who needs that support, use those skills, that motivational interviewing skills, to help them access these resources, because it is a very well established risk for infants to experience SIDS and a host of other outcomes related to their respiratory and brain development if the caregiver is smoking prenatally or postnatally. And that can include people who are just members in the house as well. So some of the recommendations that we have is that if people in the house smoke, or people who are associated with the infant smoke, they do so outside and away from the baby, especially in any of the zones where the baby would sleep or would sleep in the future, because I'm sure all of us know at that point the tobacco sticks to your hair, your clothing, etc. So this is a little bit extreme. It's not feasible for everybody, but even after a smoke break, or when someone's coming home from a smoky environment, taking a shower and changing your clothes is an extra step to help protect baby from that tertiary or third-hand smoke exposure. And all right, so before, I'm going to give us a little break because I've been rambling at you for 48 minutes now. So we're just I'm gonna just take a quick deep breath. I invite you all to stand up and stretch your legs, take a bio break, go get your glass of water. Some other trainings that I've been in, they've been like, you can do one task, not two, one task. So feel free to help yourselves. We'll come back in about 5 minutes, and then we get to talk about some of the protective factors. So the good things that keep babies safe instead of all the negative. Sound okay? We'll come back at 10:53. All right, just about a minute more. If people want to start coming back. All 201 of you. There's 201 people on today's call. So even though you might be alone at your office or at work or someplace, remember that you are not alone. You are in a room with 200 people, all of which are so dedicated to the people of the Commonwealth. Oh, great, Sammy. I'm so glad to hear that the back versus stomach slide is helpful. We actually have this available in Spanish and English on our website as well, so that you can, it's just an image. So if you're using a tablet or anything on your visits or work with families, you should be able to just add that and reference it whenever you want. All right, and I did, before we move on, I missed a question in the chat from Shelly earlier. So I'm going to go back. I'm going back to this slide to answer that question really quickly. The question from Shelly, hopefully Shelly's here. Actually, Shelly, can you get a sign that you're here?
Yes, I'm here.
Thanks, Shelly. Just didn't want to answer your question if you weren't here. So Shelly's question was about side sleeping and stomach sleeping once an infant is able to roll from their back to the front. So it basically, once an infant's able to roll over on their own and get into whatever position that they want to sleep in, the advice is to just let them sleep however they want to. And that's because they have the ability to move themselves. So even in this situation where they might be spitting up and have it go back down their trachea for breathing, the thought is that they will have a reaction to that. They'll move themselves around. They'll do something that will allow them to free themselves of the choking hazard that's been presented by the spit up. So it's not necessarily that stomach sleeping is safer or better for an infant who can roll from front to back. And even once they can roll from front to back, it's still advised that you always put the baby down to sleep on their back, no matter what. That it's just simply that they now have the ability to do a little bit of rescuing of themselves. That's another reason that 1 to 4 month is such that high risk period, because that's really before the baby is that's before the baby's able to roll around or turn itself from front to back. So they can't get themselves out of difficult situations. But it's not that once they can roll, it's not any safer for them to sleep on their belly. And Julia asks, so best position is on their side. No, best position's on their back, always back, 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 ABCs. And Nina says, what if a child is constantly stuffy due to allergies? Is that still okay? Yes. Back sleeping is still okay. But you should encourage caregivers to talk to their pediatrician. There are certain times when side sleeping or stomach sleeping is advised. That's mostly in the case of GERD, acid reflux, or a cleft palate. So definitely check with the pediatrician or the physician about that. But even with allergies, back sleep is still best, because even with the drainage from the sinuses, it'll just go straight down this esophagus, right into their belly instead of into their lungs. Okay, or could you help them by placing something under the crib to elevate it? I have a teacher has asked this as well. The American Academy of Pediatrics and we at the Department of Public Health do not recommend those, what they're called wedging devices. So they're things that you can either put under the infant or the mattress to create an angle so that the baby is upright a little bit more. We've actually seen deaths related to those where the infant has rolled down to the bottom of the crib because of that wedging device and become entrapped and suffocated. So we do not recommend wedging devices. There are a lot of physicians and pediatricians that still recommend those things. Work closely with the pediatrician or physician, but they should be used with an abundance of caution if they are used at all. Okay. Any more questions on the back to sleep part? All right, now I'm going to make you dizzy by flipping through all these slides that we already did. All right, protective factors. Breastfeeding is a known protective factor against both SUID and SIDS. Oh, I see. Is it okay to, one more question on the back to sleep. Sorry, folks. Is it okay to prop a child on a pillow, especially cold season? Pillows are really dangerous. They're so soft and squishy that if babies get their face into them, they simply can't breathe and rescue themselves. So it's not advised to put babies on pillows. Even during cold season, propping is not advised. Any kind of wedging is not advised. Anything that's soft is not advised. Thank you, Idalia. I hope I pronounced your name correctly. Okay. Protective factors. So back to breastfeeding. So breastfeeding is a known protective factor for SUID. It's really excellent in terms of the nutrients that are given to the baby, the skin-to-skin contact, the time with and bonding with the caregiver. There's just all sorts of loveliness about breastfeeding. It is very difficult. So while we want to promote as much breastfeeding as possible and really create environments where people who are breastfeeding can thrive, it's not always a reality. And so I just wanted to encourage you all too, if you're working with a caregiver who can't or won't breastfeed, there are abundance of other protective factors that we can lean on in those environments as well. So supervised tummy time is one of those as well. Sammy, good timing. Any resources or tips about acclimating young babies, those developing upper body strength, to tummy time? I'll get to that in just a minute. But supervised tummy time is so great on so many factors. It helps with brain development, helps with neck and shoulder development. It helps with breathing and arm strength and gets those babies rolling, which we know is a protective factor. Once they can roll, they can escape things a little bit better. So it's really wonderful as long as they're supervised and awake, because tummy time, if they fall asleep, they're on their belly and then they're going to be at risk. And oftentimes it's not in the crib that we're doing tummy time. So there's other factors. So if baby's not ready for tummy time, it's not time to do tummy time. A pacifier with no attachments. We talked about that a little bit earlier with how it clears the ears and the throat and keeps them aroused, like just slightly aroused. It's just really wonderful for babies. And then skin to skin is, we don't totally understand all of the science behind why skin to skin is so wonderful, but when a caregiver's bare skin and an infant's bare skin are put together, it helps regulate the baby's breathing and body temperature, helps stimulate their brain and endorphins, and helps the caregiver and the baby bond. And all of those are really great things that help protect against SUID, as long as it's done while everybody's awake, once again. So breastfeeding, it really does reduce the risk of SIDS. But if baby falls asleep during or after breastfeeding, it's important to get them up and moved, make sure that they're supervised and safe while they're asleep if you can't move them immediately. And then here's a piece that you might not have heard in other safe sleep trainings that I want to frame up for you the right way. If the breastfeeding person is sleepy during or after breastfeeding, like if they can't stay awake, and I've breastfed 2 kids now, I certainly fell asleep. It is hard work and it's a full-time job. So if the parent can't stay awake while they're breastfeeding, an adult bed with no blankets, no pillows, no loose sheets, or any other objects or people in it is safer than a chair or a futon. So that means if mom's fallen asleep, give her permission to go lay down in a bed and feed that baby, but clear off all the other stuff in the bed. Make sure that that space is as clear and as clean as possible. But it's better to be in the bed than have baby fall off of the futon or the chair or get entrapped in the futon or the chair where mom's trying to stay awake. Like I said, we saw a lot of those cases when the American Academy of Pediatrics first came out with their guidelines. And I have a couple questions coming in on the chat. We'll talk about acclimating babies to tummy time in just a moment. How long until what age is skin to skin believed to be beneficial? I don't think that there's an end date or time on it, to be honest. I haven't seen any literature that talks about when skin to skin is no longer beneficial. Usually we talk about this in terms of the first year of life. And it doesn't have to be the birthing parent either. It can really be any caregiver. And how old should a baby be before putting them on a pillow to sleep or eat? Babies should be able to do it themselves so I've seen a lot of people, use the boppy or a pillow to prop baby up and give them the bottle. And I've seen lots of ingenuity. Parenting requires a lot of ingenuity where they've tried to prop the bottle up. That's really not advisable. It's more advisable to be with the baby, holding the baby and feeding them until they can sit up and hold the bottle on their own. I hope that helps. Tummy time. So if your baby doesn't like tummy time at first, start with really small increments. So even 5-10 seconds just to start to get them in that position, start to get them pushing up. It's exercise. It's hard work. I don't know about you, but I don't particularly love exercise. It's hard work. So babies are going to have a similar reaction to it. So just really small increments growing in time over time. And then find something else that works for them too, like a little toy that's just barely out of reach or something for them to watch or look at while they're on their belly. And then advising caregivers to get down on the ground with them. Because again, supervised tummy time is really important. It's not tummy time where the caregiver walks away. It's tummy time where the caregiver is watching and involved with the infant. So sometimes it can help if the caregiver gets down and looks into the baby's eyes and really does that connection with them, and for however long they can stand it. So, and it's okay for baby to cry in that position. Babies cry. It's an absolutely normal part of development. And it's wonderful that they can cry because it's their only means to tell us that they want something. But it doesn't mean that they necessarily need to be moved from that position right away. It's so healthy and beneficial for them. I hope that helps with the acclimating a little bit. It's tough work, but babies get used to it over time. And pacifiers. I think we covered this one enough. What time should tummy time start age-wise? Within the first month. Tummy time is really advised right from the get-go. My daughter was born on December 13th, and I have a nice picture of her under the Christmas tree doing tummy time. So she was just a week or so old at that point, but right away, right from the get-go. Especially when we're talking about back to sleep, infants can start to develop a flat spot on the back of their head from back to sleep. So tummy time helps them prevent that so that they don't have something pressing against the back of their head like they would in a safe sleep environment. And it also helps with torticollis, which is when one piece of the muscle starts to develop more rapidly than another. So it really helps even babies out and get that development going from a very early age. Is doing tummy time on mom's belly okay? I would recommend both, and it's great when you're leaning back on the couch and baby's on your chest. Anything that does have them kind of like looking up and looking backwards, extending their arms, using their abdomen, that all counts towards tummy time. I think I've even seen some of the Bjorn or baby carriers can count towards tummy time, but having that alone independent time on a flat surface can really help as well. So mix it up. It's like an exercise routine. Mix it up. Yes, and it can be done on the caregiver's chest. Thanks, Stephanie. All right. Skin to skin. I think we've covered this one too. And again, I want to reiterate that it should not be done if the caregiver is at risk of falling asleep. And even in some birthing hospitals, they won't allow skin to skin to be practiced unless the caregiver or the parent is supervised with the infant because they're worried about the risk of falling asleep. But it is wonderful for the baby. All right, let's talk about room sharing and bed sharing. There's a lot of definitions and nuances that go into this. So I'll try to slow down and make sure that it's as clear as possible. So the three main terms that are kind of used a lot and without a lot of clear definition, I find, are co-sleeping, room sharing, and bed sharing. So co-sleeping, often I hear it used in kind of a negative connotation, like, oh, they were co-sleeping. But co-sleeping is really just a parent and a child sleeping in close social or physical contact of each other, meaning that they can tell each other that the other is nearby. So co-sleeping is, at the end of the day, it can look like room sharing or it can look like bed sharing, but it is something positive. So co-sleeping is something we really want to encourage, having that, especially the under 4 months old that we know are at the highest risk for SUID. We want to see them in the same space or room as their caregiver. It helps regulate breathing, it helps regulate their heartbeat, and it helps the caregiver be more responsive to the baby if the baby has any needs during the night. It can also help the caregivers get a little bit more sleep rather than getting up and going to another room. It's also very helpful because not everybody has a lot of space in wherever they live. So it's great to have that infant in the same room as the caregivers. And that is called room sharing. So that's when a parent has a crib, a bassinet, or a play yard near the bed and in the room with them. So not in the bed, but in the room with them. Important caveat about this one too, you want to make sure if the bassinet or the crib or the pack and play is right up next to the bed, you want to make sure that nothing from the adult bed can fall into the crib. So I've seen some that are kind of at a lower angle from the bed. there's a risk of pillows or other unsafe objects falling into the crib or bassinet. So you want to try to make sure that it's kind of equal surface. We're also seeing a lot of open-faced cribs that kind of pull right up to this. They're called co-sleeper or side sleepers. Those allow the baby to roll into your bed, or soft objects from the adult bed to go into the crib. So those should definitely be used with some caution as well. And then bed sharing is when a parent and infant sleep together in the same bed. This is pretty risky. And we don't have a lot of great data about the number of people who are actually bed sharing versus how many infants are dying in a bed sharing environment. But we do know that a lot of the cases that we see come through did have bed sharing involved with it. So we want to make sure that we highlight some of that and talk it through a little bit more. So with the room sharing, keep baby's sleep area in the same room for the first 6 to 12 months. Now, if a caregiver is having a hard time sleeping and is ending up, and the baby's in the room, they're room sharing, but they keep on pulling the baby into the bed with them, that might be a time to talk to them about moving the baby to a different room. There's some literature out there suggesting that room sharing after the 6 months can actually lead to increases in bed sharing, because infants are exhausting and anybody's just trying to get sleep between that 6 to 12 month mark. So after the 6 month mark, or even maybe a little bit sooner, if it's safer for the infant to go into a different room, meaning they won't practice bed sharing if the infant is in a different room, then encourage them to do that. But it does decrease the risk of SIDS by as much as 50%. Okay. Now, bed sharing, this is the big one that we want to talk about quite a bit. So caregivers, these are the risk factors that exist in the bed sharing environment. A lot of times, if the infant might sleep very closely to the parent on their side or on their stomach, that's a risk factor, regardless of whether or not there's anybody else in the bed. Also, if the caregiver experiences obesity or neuropathy, it means that they might not have as much feeling in their extremities, which means that they're at increased risk for a rollover on the infant, which is just a terribly tragic way to lose an infant. Another thing is that if the infant and the caregiver are laying on the bed and the caregiver's side is depressed a little bit in the mattress because of their weight or just the inequity between the two people's sizes, the infant can roll towards the caregiver and also cause an entrapment hazard with the individual, with the caregiver. Also, if caregivers are using any kind of medication that makes it hard for them to rouse or causes drowsiness, that's also very risky in the bed sharing environment. Same with prenatal drug use and alcohol use, and if they're sick or unusually tired. So if a caregiver is experiencing or doing any of these practices, that's very risky, and bed sharing should be avoided. Similarly, for an infant, if an infant is less than 4 months, that is not recommended for bed sharing. And these are all the same risk factors that we had talked about previously. So bed sharing, if an infant has any of these risk factors already, it's not a good idea to bed share. So bed sharing does increase the risk for SUID, but we acknowledge that there are times when parents and caregivers might bed share for cultural, personal, or circumstantial reasons, including getting some sleep because everybody's really tired. So when you're working with caregivers, it's important to understand their beliefs about bed sharing and discuss risk reduction and positive behaviors in the bed sharing environment. To bed share as safely as possible, and this is on mass.gov/safe sleep if you want to dive into these resources a little bit more. You want to make sure that the baby is always placed on their back to sleep and that their neck is extended. Have to check and fix any gaps between the headboard, the wall, and the bed frame every night. One suggestion for that is to actually move the mattress onto the floor so that there's less distance for the baby to fall or less for the baby to get entrapped in. Making sure the mattress fits snugly in the bed frame. Removing any toys, blankets, pillows, bumper pads, or window cords from the bed as well. So that includes sheets, it includes fluffy blankets and pillows for the adult caretaker. It also includes any other people in the bed. So it's caregivers who are not breastfeeding are at even higher risk for experiencing rollover or otherwise entrapping their baby in the bed. So it's really important that no one else be in the bed with baby. All right, another pop quiz for you all. Which one of these babies is sleeping safely? And you can use the chat. Don't put it in. Oh, Joanne already got it. All right. See a couple A's coming in. All right. Wow, lots of A's coming in. But C is so cute. C is so cute, isn't it? I mean, they're all so cute. Who doesn't love a good sleeping baby? All right. The correct answer is, oops, A. And let's talk through some of these risks. So this baby, they're up on their side. So it's if the baby got there that way themselves, then maybe that's not so risky. But we like to see babies sleeping on their back. And they also have this little device on them. I don't know if folks are familiar with this, but this is a new kind of swaddle that has a built-in weight in it that makes it feel like the baby has a caregiver's hand or something on their chest. This is not an evidence-based sleeping device. We don't know what kind of risks this does or does not pose for an infant. And generally speaking, if we don't know if it's protective or causing a risk, we recommend avoiding it. So that's another reason that this baby is not the correct answer. And then this little cutie pie with the bear. This bear has a couple of challenges with it. One, it's a suffocation hazard. It can easily block those little tiny nostrils in that mouth, but also the button eyes are a choking hazard. So this is not a great thing to have in the baby's environment. And then in D, there's all sorts of challenges here. It looks like maybe this caregiver is actually awake and just pretending to be asleep. But these sheets, this blanket, and the caregiver all pose risks for this infant. And Kira asked in the chat, is there liability involved with recommending bed sharing, even if we're sharing these strategies? So I would never recommend bed sharing to a caregiver. I would, if they disclose to you that they are bed sharing, I would talk to them about strategies that make it safer. I would not suggest taking on bed sharing if they're not already. And what is the fabric on the side of the crib with the baby on his back? Thin bumper pad? It could be a thin bumper pad. I hadn't noticed that. Thank you for pointing that out. It could also just be the sheet, but you're right. That should be tucked in a way so that it's not, can't interfere with the baby. What age is it suggested to stop using those sleep sacks or Merlin suits? We don't have a recommended age for stop using sleep sacks. Sleep sacks are great. They can provide a lot of warmth and comfort while also keeping the arms available for babies. So they're actually much more recommended than, for example, a swaddle. Eventually they stop making sleep sacks that are big enough. I think I've known of 3-year-olds who are still in sleep sacks, but they're hard to find sleep sacks that big. So generally babies size out of sleep sacks. And Jackie, do you have a question? Yeah.
No, I have comments.
Go ahead. All right. All right. So B looks like the baby can turn on its own, but I might be wrong. Yeah, I'm not sure. We're not sure. But still, this device is not something, and that goes for like the, maybe it's just a small head. Maybe. We'll take a look at these pictures and update them for the next training. Thanks so much for pointing out some of these flaws. And so I talked about this sleep sack a little bit. That goes the same for those little things that people can put on babies' feet that check for oxygen level, or, you know, there's alarms that will go off if they're worried that but hopefully you know what I'm talking about with those little footies that can measure oxygen and breathing. Those have a lot of false alarms on them. We do not recommend them as SIDS prevention. What happens is caregivers tend to start to ignore alarms that go off too frequently, so they don't actually provide the protection that's expected. And also usually once those alarms are going off, if it's a true instance, it may already be too late. So it's better to have these other protective factors in place than to rely on a device that could be faulty. Can I repeat what I said about sleep sacks? Yes, sleep sacks are great. Sleep sacks are wonderful. They're a really great way to help babies stay warm and comfortable and cozy without posing a suffocation hazard. Babies can stay in them for as long as they want to. There's just a size limitation eventually that comes up with, I wish they made a sleep sack for me, but I don't think they do make those for a full-size adult. So sleep sacks are great. The things that you want to watch out for are the really tight sleep sacks. So we want to make sure the baby's hips don't get hip dysplasia. So swaddles and really tight sleep sacks can cause hip dysplasia. So we want to make sure that they're a little bit loose, and things with weights in them. Like this one on the screen has, those are not evidence-based. We don't know that those are a protective factor and they could cause harm. We're not sure. We don't have enough data or science about it yet. A sleeping bag for me. I'll ask my partner for one for Christmas, but I need the armholes with it too. I think those are called a slanket, maybe. Yes, Fiona, I am so excited about DHCD recommending sleep sacks for all babies entering shelter. That's wonderful. All right, let's talk about some strategies for sleepy caregivers. In my experience, this is the #1 barrier to practicing safe sleep. It's just simply how exhausting it becomes as a new parent. So one thing, I think I would change the order of these if I could a little bit. The developing a commitment to a plan and routine and having that before baby comes. It's really hard for especially new parents to think what their life will be like once baby arrives, but that's a great time to start talking to parents and caregivers about safe sleep, having a routine, making a plan. So what happens if something goes wrong? Where is baby going to sleep? Who's going to sleep in the same room as baby? What's my goal for how long I want baby to stay in my room, etc. Just really having that, thinking it through and trying to lean on how tired and exhausted it will be, because it is pretty much an inevitability with newborns that you're going to have sleepless nights. So having that plan before baby arrives. A lot of times the first time parents are hearing about safe sleep is in the hospital after birth, and that is not a time to retain information or make a plan. It really needs to happen a little bit further upstream before baby arrives so that they can put all the pieces into place that they need to put into place. And one recommendation is to put a baby in the crib while they're still awake so that they can learn how to self-soothe and get themselves to sleep, and then caregivers not at risk of falling asleep with them. Consistent, regularly scheduled naps often result in good quality sleep. And a baby that gets good quality sleep is much more likely to sleep longer and be less fussy and give their parents less of a hard time. So good sleep equals easier to practice safe sleep. And what if something unsafe happens? So these are all good things to bring up to caregivers as well. And Katie says, I tell expectant parents to make their sleep a priority. Too often the message that new parents will be exhausted and get over it. Make sleep a priority. It's so true. Sleep for baby and sleep for self, because everybody needs it. Okay. So if the infant, these are great things to share with your caregiver or with the parents and families that you're working with, just in terms of things for them to have in the back of their head as they're working through their day-to-day lives. And again, the sooner they can get these messages, the better. So if an infant falls asleep in an unsafe area, make sure that to move them as soon as possible, supervise them if they can't be moved, make sure their neck is extended and nothing can fall on or in front of their face. If the caregiver can't stay awake, try to get someone else to help, which is not always a reality, especially in our present day circumstances with less community connections and COVID. So if you can't get someone to help, an adult bed or the floor with everything removed is safer than a chair, couch, or futon. I know I definitely leaned on the floor more than once when I was trying to raise my infants and simply needed a break. If the parent or caregiver wakes up while holding the infant, move them immediately or move to a safer location. So you'd say both of them fall asleep on the couch and parent wakes up. If baby's still asleep, get them into a safer place. If caregiver still needs to sleep, move to a safer place. Right. All right, now it's your turn. We're going to hear from you a little bit. We've heard a little bit from you today already about questions around jewelry, clarification about wedging devices and pillows and propping babies with bottles, etc. But tell me a little bit more. What have your challenges been? What cultural practices or beliefs have have concerned you when it comes to working with families and caregivers on safe sleep? You can raise your hand, you can put it in the chat, you can just unmute yourself and talk.
Hi, everyone. I'm Jenna from the Care Center in Holyoke. I work with young parents and I'm in administration, but I supervise the counselors. And one of the things I observe a lot is our young moms under 24 are on the move, and those infants go everywhere in car seats and with really little babies. And so I'm kind of listening to the chin tuck in the airways, and the babies are all kind of folded up in these little car seats. So I'm not quite sure what to do about that, because young moms are hanging out and going places, and of course they're transporting their babies in car seats.
Yeah, I've seen that a lot. I've done that a lot. I think that's a great thing to focus on, is, really teaching them about the chin tuck. Like the chin falling forward like this, or baby falling forward in the car seat, it can block their airway. And we definitely have seen cases come through that way. So that's a great thing. And, since you brought up car seats, I do want to let everybody know that we've seen a couple fake car seats here in Massachusetts in the recent past. These are car seats that don't meet any federal standards for safety. So give parents a head. I'll circulate a flyer to you all, but that's another piece to look out for, because motor vehicle crashes are actually another leading cause of death for our children and young people in Massachusetts. So I'll give you some more information about that afterwards, but it's great to have moms that are on the go. It's great that we have those resources and ability, but really keeping out for that chin tuck and making sure the baby does get some really good quality sleep on their back is helpful.
What can they do about the chin tuck? No, little
They
child.
might have to readjust the car seat or lean the car seat back a little bit, or just put that baby's head back. It might just be a matter of putting the head back. And then if baby's head keeps on falling forward, it could be a good time to go to a car seat inspection station. A lot of fire and ambulance services will run those. Make sure that the baby is strapped in the right way, because their head should not be falling forward in the car seat. Okay. T. Jenkins, I saw your hand come up.
Hi, how are you, everyone, today? I apologize. I missed a lot of the meeting in the beginning, so you may have already talked about this. But I know in my culture, and I see it a lot in young women that have babies, they tend to lay the baby down on their stomach and get a baby a bottle, and they're patting the baby's back and let the baby fall asleep with a bottle in their mouth. I don't think it's a safe practice. I'd love to hear from you more about it. Also, one of the challenges that I see here at the facility that I work at, is a lot of moms keep the baby in the car seat for restriction reasons. Maybe they punishing them, maybe they're trying to do something. So while they're active trying to clean the room or do chores, I see moms strapping babies in car seats and leaving them there for a good amount of time. Also, I even noticed today that I saw a child that looked like they were too big for their car seat. So I'm going to reach out today and try to get them another car seat. But, these are the challenges that I see and face, but I'd love to hear what you have to say about them.
Yeah, thanks. Okay, so baby being put to bed with a bottle, that is actually a big risk for ear infections. So you might want to warn those parents that they could be causing challenges for themselves in the long run with that practice. It definitely is. As they're drinking the bottle, if they fall asleep, it pools into their mouth and can cause infections in their ears. So it's not necessarily, I'm not as worried about it from a safe sleep perspective, although I'm sure it's not good, but it is very bad for their ears. And the car seat, so we did a car seat training session last month. We have a recording of that I'll send out, or I'll ask one of my lovely team members to get out to you. It's hard to tell whether or not a child or an infant is too big by their car seat just by looking at it. You have to look at the height and weight restrictions on the car seat. And especially if they're still doing a rear facing car seat, it's okay if their legs are kind of like dangling over the edge or pushing against the car seat. That's more of like a comfort thing than a safety thing. We really recommend rear facing car seats for the first 2 to 3 years of life. So even if it looks like they're a little bit too big for the car seat, it's much safer than putting them in a forward facing car seat. But there are lots of inspection stations and resources and materials to help with that car seat piece. Did I get it, T. Jenkins?
Yes, only thing I didn't hear you mention was about the restriction, people leaving, moms leaving babies in the car seat while they're doing other things.
Yeah. That one's a tricky one. For me, when I hear that, what I hear is a caregiver who needs more community support and more needs, because we are all humans just trying to do our best, take care of ourselves, take care of our responsibilities, and take care of our lives. So if they can't keep up with their baby and they're using it as a restraint or, just to give themselves a break for a moment, that to me sounds like they could use a little extra support at home in terms of someone else who can take over for a minute. Not all of us have that. I've seen that a lot even with like pack and place, like putting babies in pack and place for a while. It's not necessarily a safety concern, but it is a concern from the perspective of the child's development and making sure that they get that free range movement and learn all of those schemas like throwing and jumping and climbing that are really important to long-term brain development. So I would say working with those parents or caregivers on finding ways to get them some breaks and get some more additional support in the house so that they can have time to engage fully and happily with their infants and also have the time to take care of their needs.
Thank you. I appreciate your input.
Yeah, it's not an easy one at all. And unfortunately, I feel like our communities and society have a long way to go in terms of supporting new parents and giving them, it takes a village, and we don't all have a village, especially following the pandemic. All right, Kira, I saw your hand up too. Kira Hamilton.
Hi. So I guess one of the things that I've come across often is like we talked about before, the overdressing. So I see a lot of newborns with hats on and things like that. So I guess I'm just wondering like what the best strategy would be to talk to the parents about those things, because I know that can be cultural or it can just be like the lack of information. Like I know when I had my children, the nurses were really good about saying after the first 24 hours, they don't need the hat to help regulate their temperature. So that's information I try to pass on, but I didn't know if you had any other strategies for talking about overheating, because oftentimes I'll come over and they have like many layers and they have the mittens and they have the hat. So I just wanted to know if you had any ideas for that.
I think that's a great one, you know, that the hat is really only necessary for the first 24 hours. And I would definitely recommend that you coach them on looking for signs of overheating, like redness, sweating, fussiness, and say that it's not just that it's not comfortable, it's dangerous for baby. Babies are really sensitive to overheating, so that's not necessary. And one thing that you might want to point out too is the mittens aren't necessarily for keeping their hands warm. It's really for scratching. So if they don't have a problem with scratching, they probably don't need the mittens, and that it's not really intended to keep them warm. You know, I've seen that a lot with especially people who are coming from warmer climates and now live in Massachusetts. Cold is dangerous, but so is overheating. So I think that's one piece that we often miss when we're talking to folks. Is it's very obvious that frostbite and cold weather can cause a lot of harm, and it's not as obvious what overheating can do to an infant, and it really is very dangerous. So I think those are my only recommendations. But if other people have recommendations or face similar challenges, welcome. I invite you in too.
Would you say that overall, it's fair to say that overheating is more dangerous than being too cold? Obviously, I know on both ends it's dangerous, but would that be an accurate thing to say?
I would say that's a hard one because I wouldn't want them to compare like overheating to like leaving your infant outside in 30-degree weather. You know, like there's extremes in the temperatures. I would say it's probably similarly dangerous, but less obvious because you're inside the house, you're in a comfort space. Like you don't think that you're going to overheat in a space like that. And I don't think everybody knows like the discomfort of going out in really cold weather and how that can lead to frostbite. Like that's a very obvious thing that you feel, but you might not necessarily feel, and might ask the caregivers too. Like one thing that we recommend is that you dress the baby similarly to however you're sleeping. So if you're sleeping in a t-shirt, probably baby only needs a t-shirt. If you're sleeping with a blanket and a sweatpants and a sweater, baby probably needs a couple layers of clothes when they go to bed. But babies aren't so different from adults. They need something drastically different. So reflect on your own attire for sleep and then try to mirror that for baby, making sure that they don't sweat. And you know, most of us don't wear hats to bed, I think.
Yeah, no, that definitely makes sense. Another thing too that I had seen in the past and may be helpful, I had used it for my own children just as a guide, is it's an image or a handout where it shows you based on the temperature what the child should be dressed in. So, you know, if it's this amount of degrees, the child should have just a onesie, or you know, a certain temperature, the child should have a sleeper and a sleep sack. So maybe I can start using those resources with my clients as well.
Definitely. And I think we link to one of those on our mass.gov Safe Sleep page as well. I find that to be a really helpful resource in talking to parents. Thanks for reminding me.
Okay, thanks for your help.
Thank you, Kara. All right, we've got lots of things in the chat here too. Okay. So I see one here that says co-sleeping has been a struggle with moms that are not from the US, and moms who suffer from being overwhelmed and have other children keeping the infant in the car seat while they're cooking in the kitchen, etc. And when I work in congregate care settings, and sometimes having a baby in a car seat or, you know, away from other children or infants or risks is actually a protective factor. I would say, you know, especially with the cooking going on, we see so many people who hold their infants while they're cooking. That's pretty dangerous from a burn standpoint. So if you're doing some like positive reframing, it might be helpful to think of that restraint as keeping the infant away from other potential hazards. But for the co-sleeping with from parents who were not born in the US, I think it's important to remind them that things are that the circumstances in the United States might be different. So have them reflect on what their bed was like in their home country versus what the bed is like here in the United States. In the United States, we tend to have much thicker mattresses with a lot more pillows and bedding and comfort objects in them compared to something that might be a more simple, thinner mattress that is more firm in nature. So that might be a helpful conversation. What did your bed look like there versus what is it like here? What are the differences in the risks in that environment versus this environment? In the homeless shelter, we have lots of problems with parents keeping their babies sleeping in car seats and carriages. So again, you know, if people don't have resources, if they don't have space for a safe sleep device like a pack and play crib, etc., they may very well lean on these other devices that serve more purposes than just a crib, like a car seat. And it's not advisable, but it is better than sleeping in a bed with a parent or other adult or someone else. So thinking about all of those, meeting people where they are and providing the resources is really helpful and important. So if you can get them a safe sleep device, or if you can coach them about like making sure that the baby's chin isn't tucked, and some other things to watch out for, I think that is helpful. I've seen some families use a baby head strap in the car seat to keep babies from falling forward. That would probably be okay if baby is not in the car. I'm not sure. I haven't seen a lot of research about this. Certainly while the baby is in the car, nothing should be attached to that car seat that didn't come with the car seat. If I can imagine that having something strapped onto their forward when you have such a violent act as a car seat, it could likely hurt their head and their neck and potential other places in their back. So definitely no straps on heads in car seats that are installed in a car, in a moving car. The misinformation, which comes from a number of sources, past experiences, elders sharing advice, not knowing what you don't know. It's so true. And advice has changed. Even now, we have a new policy from the American Academy of Pediatrics that came out in the past couple months. It's very hard to keep up with. We do try to provide trainings to older adults, and we're always trying to get the messaging out, especially since we have so many grandparents raising grandchildren in Massachusetts. But it's a hard one, and that's one of the things that we encourage and hope that you'll all be able to do is get more people involved in the safe sleep practices of the families that you're serving, to make sure that they're not alone in the practice, that they have other people supporting them. Stephanie, I saw your hand raised.
Yeah, I had put that comment in there. I think oftentimes, there are things that we just know are safer, right? And we're in the luxury of having information because we're in the professional role. We've probably done it, but oftentimes, I have professionals who are friends and they have a baby for the first time and they're clueless about, even with all of the apps and the books and the what to do and what to expect. And then they're there and they're in it. And if you've had a child, whether, whatever the case might be, you're exhausted, right? So the getting the information and processing. And so to that point specifically, it's more so about when we're sharing information, right, to help safer practices for families who may not know. Often it helps, instead of just assuming this is wrong, which we know it might be, but it's more so about trying to understand where they're coming from. Because again, when we talk about social determinants of health and we talk about some of the disparities that lead to what we're talking about, there are things that parents can't control. And so it helps sometimes to try to understand what they're thinking and then helping to support them to kind of what the safer practices are versus just coming in with the hard and fast, no, that's wrong. You know what I mean? Because you're probably not going to be able to modify a behavior just by saying you should be putting your baby to sleep on your back. You want to understand their rationale to help guide them to a place of kind of learning and understanding why it would be safer to put them on their back. So that was more so that perspective.
I love it. Could not have said it better. Thank you so much, Stephanie. So valid and important. And yeah, I used to do safe sleep trainings, and then I had an infant and was like, oh, this is way hard. So I do try to bring that in these perspectives because it is a really intense moment in someone's life. There's a ton of more questions coming in through here, and I have a few more slides for all of you too. So I'm going to try to run through a couple questions that have come up. One was about increasing the whole in a bottle and adding cereal to milk or rice to baby's formula. This is not a recommended practice. It can cause suffocation hazards and a lot of spit up hazards. I think there's even some of the regulations for early education and care, I think, make it prohibit that practice. So I think working with, a lot of times people think that if baby is really well fed and has a very full belly, they'll sleep better. But this actually puts baby at increased risk for choking on their spit up. And again, we don't want that ultra deep sleep. We want babies to be able to rouse themselves. So it's ultra deep sleep is great for a moment, but it's not great in the long run. Another one that came up, hours of sleep. How long it is, and babies are really different. There's some charts online that I can try to pull up after this training that talk about the expected amount of sleep, but every baby is different. Some of them will get those 12 hours of sleep in 20-minute increments. Some of them will sleep 8 hours the first night that they're home. And it's really, really dependent on the baby, but the more sleep, the better. It's really important. And then there's a question about baby boxes. We do not have baby boxes available in Massachusetts, and the Finnish baby box success story is much more complicated than the baby box alone. The baby box is like the most visible feature of a very progressive and robust family support service provision that Finland created, where families and caregivers have at least 12 months of paid bonding time with their baby. They have really beautiful access to adequate prenatal and postnatal health care. They've got more access to childcare services. And then that baby box is really just the icing on the top, and it comes with all sorts of education and information. What was recommended and what was put forward in Massachusetts was simply the baby box without that improved access to prenatal and postnatal care, without the paid, well, we do have paid family medical leave now, but it's not nearly as long as it is in Finland. So what the baby box in and of itself is not a protective factor. It's really the whole system and policy structure that was produced in Finland that led to that much lower infant mortality rate. Sorry to be a Debbie Downer. At what age do we stop swaddling our baby? Swaddling can, again, we only recommend it for soothing a fussy infant. So as long as it's working to keep that, to get that infant more calm, it can work. A lot of times babies don't like it past the time that they can roll. So generally swaddling stops around between like 6 and 12 months of age. Whoop, can people hear me? I just heard that I've got no sound. You can hear me? All right, thanks for the nods. All right. Good. And Kira had put in, I just wanted to suggest to open the airway in the car seat. I have luck with gently turning the baby's head to the side instead of straight back. Since some of the car seats have a lot of padding included, open the airway, but pushing the head back doesn't always work. So maybe off to the side. That's a good point. Thanks, Kira. I'm sure that I missed some questions in here. And we have a lot more resources that we'll share with you as well. And Michelle put in a really good point here about moms getting defensive and feeling like they're judged as a parent, so they put up a block. I totally understand that. I've certainly got defensive myself a number of times. And then again, it's about meeting families where they are, supporting them and helping them understand the whole perspective, getting them to the resources that they need, and doing it without judgment. I think that motivational interview training is a really helpful way to start working with families. And so if you haven't been able to attend one of those, that's a really good training to attend. Okay. Let's see. Let me get into some resources for you all, because I think that will be helpful. Sharing my screen. All right, we should have my screen back now. All right, so some tips for safe sleep conversations. Understand the cultural beliefs of the parents, families, and caregivers. And again, it's the more people that you can pull into that support system for creating that safe sleep environment and practicing safe sleep, the better. So it might not stop with mom. Mom might need help convincing grandma or grandpa or dad or someone else about why they should be behaving this way. So really help them understand where they're coming from, what their challenges and barriers are, and work through that, even if it means having conversations with other people. Asking open-ended questions can help with that sense of judgment and defensiveness. Clarify risk factors and reinforce positive behaviors. Find those strengths. You know, we always want to take a strength-based approach. Find what they are doing right. Make sure that they know it and they hear it, that they are doing something right. Discuss harm reduction behaviors for families that are willing to adopt safe sleep practices. So that's back to that liability for the bed sharing versus not bed sharing. If they're already doing it right, great, move on. If they're not doing it in the safest way, try to introduce some things that will reduce harm, and make sure that you're framing it that way too. These babies are still at risk, but these are things that we can do to help remove some of the harms from the environment. And engage community and identify a safe sleep champion. So if you've got someone who's really good with the safe sleep, figured out how it works for their family, use their stories, leverage their work, see if they're willing to come in and talk to other families if that's something that works for you or for them. You know, really those champions, those people who have walked through it are really important for helping spread these practices and this work. And we have a reference guide for you. I mentioned this a little bit earlier on. This is available for download and in free print copies mailed directly wherever you want it mailed, as well as in English and in Spanish. You can use this guide to understand a little bit more about the risk and protective factors and practices that families are using related to safe sleep. Here's some screenshots. Oh, thank you, Emily, for putting that into the chat. Here's some screenshots that just show you a little bit about what the reference guide is and how it walks through. So it asks all sorts of questions about, you know, what the developmental stage of the baby is, what the practices of the caregiver are, what the baby has already experienced. So what was their birth weight? And, you know, if you know that they had a low birth weight, that's a great time to chime in and say, you know, that's actually a risk factor for experiencing SUID. It's really important that we practice safe sleep with this baby because they're technically at increased risk for this very negative outcome. And it's several pages long. It has lots of space for you to write your notes. The vision for this is that you would use one resource guide per family, not that you would necessarily use the same guide over and over again. So just to walk through it with the family, understand their needs, their challenges, their opportunities, their strengths, and make a plan for how to practice the safest sleep possible. And we've got some positive feedback on this, so I hope it is a helpful tool. If you have any tips or suggestions for us on strengthening this tool, we are always more than willing to take that feedback. All right. Now, I have a couple activities here, but I think we're actually running out of time. Alexandria, if you could give me a time check privately, that'd be helpful. But we just had a couple of scenarios that we wanted to put forward to you. We'll go through, we only have 7 minutes left, but I'm going to read them out loud and I want you to reflect on them. Florence, we'll send you the link to order the copies from the Massachusetts Clearinghouse. So safe sleep conversation number one, reflect on this in your own mind. What would you do if you were in this person's shoes? What would you say to a parent who's adamant about bed sharing, even after discussing safe sleep, because she has bed shared with her other children and she wants her baby to be close to her? So what would you do in this? What are the things that you think you could introduce into the conversation to help that caregiver understand about bed sharing? Number two, what would you say to a parent who wants to use soft mattress, blankets, and pillows for their baby to keep comfortable and warm? What are some of the practices? And you, again, just reflect on this on your own. What are some of the things, the facts, the information, the experiences that you could bring in that would help the parent understand the risk that those objects pose? And then what would you say to a parent who wants to bed share as safely as possible? And again, there's tips on mass.gov/safe sleep that can help with this. All right, I promised you a little bit about grief support too. So in the last 5 minutes that we have together, I'm gonna go through some of the grief support services that are available in Massachusetts and then provide you with a whole host of links and information. And then I'm going to give you an evaluation link because I want to make sure that we hear from you about ways to make this the most engaging, most useful training that we can for you and the people you support. So this section has some quick resources for grieving families and helping the bereaved with do's and don'ts. I wanted to share with you that Massachusetts is home to the Massachusetts Center for Unexpected Infant and Child Death. They are a phenomenal resource to all of those who are bereaved from an unexpected child or infant loss. They have support groups and resource request forms. They provide books and websites. They can provide support with finding a therapist. They don't provide the direct services themselves, but they are a systems navigator and an information provider. They are an absolutely wonderful resource for anybody who's walking through this. So I want to make sure that you know this in case anyone that you come across is bereaved and needs some support. It's an excellent resource. And then how can we support parents who are grieving? First, we need to do our own self-work, understanding our reactions to feelings and experiences of grief and loss. So again, I said this early on, we can't help others if we haven't helped ourselves. We need to educate ourselves about grief and loss, demonstrate cultural sensitivity. They might walk through it differently than you, and recognizing that everyone grieves in a different way. Don't underestimate the power of relationships. Just showing up, reaching out, making that contact is usually very helpful. Giving parents permission and space to tell their story or not if they don't want to, but making sure that you're there to listen. And providing resources when and if the family requests them. We have a couple tips here too about do's and don'ts when working with someone who is bereaved. So being a good listener, you can let them know they're not alone, allowing them to talk about their child. We hear this all the time. Using the name of the child who has passed away is very powerful and meaningful. Caregivers, I've never heard of a caregiver that didn't want the name said. They want to hear that people remember because they have not forgotten their child. And understanding that there's no timeline or stages of grief. We all like to talk about the 7 stages of grief, but that's simply not accurate and a reflection of real human experience with grief and loss. And some don'ts, don't try to compare their loss with other losses. Don't wait for them to reach out to you, that they're not in a space where they can necessarily reach out and ask for help. Don't tell them what to do. Don't be afraid to talk about the child who died. And don't compliment them on their strength or their bravery. It's not necessarily helpful. And some words, I think I'll focus on the don'ts here because you all seem like you're very well versed and I'm sure very supportive. But some things that can be really harmful after an infant or a child loss, saying things like it could have been worse. Don't cry, be brave for your family, you'll be okay, aren't you over it yet, you'll have other children. These are not things that will help in the time of grief or in the moment. These are things that really diminish their experience of grief and loss and are not empowering in their recovery journey. So If you take one thing away from today's training, it's alone, back, crib, the ABCs of safe sleep, and all of these resources. So you're going to get these slides, you'll get all these links. There's lots of videos and contact information, more reading to be done, the tobacco cessation program. This Infant Safe Sleep Family Voices in Spanish is very powerful, and it does talk about infant loss. So for the person who is asking for some resources that can be shared with caregivers, this is certainly one of them. And then these Protected by You posters and door knockers and other materials are available on the Massachusetts Clearinghouse, either in print or in download. This is the most updated American Academy of Pediatrics and the DPH Safe Sleep Policy. So we've worked really hard with DCF, EEC, and a lot of other family support service organizations to make sure that our policies are in line with theirs. And so this is just a reference if you're looking to do some more technical reading on infant safe sleep and preventing SUID. Here's our contact information. And last but not least, this is the link to our evaluation today. We really want to hear from you. How can we improve this training? What worked for you? What didn't work for you? What is your key takeaway, and what are you going to do with this information? So if you could take some moments to fill out this evaluation, it would really help us in improving it moving forward. So with that, I didn't get to hear from you as much as I wanted to, but that's my fault because I ramble on too much. It was very lovely meeting with all of you. I'm grateful for all of your commitment to supporting families and caregivers throughout Massachusetts and promoting safe infant sleep. And I wish you all the best in your work and endeavors. Thank you.